Langoya is an internal medicine physician and head of department at Lachu Hospital, and also has a special interest in nephrology. And he has various posts, including leading the National Death Review team. We have myself, the publicity mobilization secretary, Dr. Joel, a medical officer in the Hospital. We have in private sector representative, we have Dr. Semo Gerele Tadeo of CCare, and we have district representatives. Lemua, we have Dr. Sharon Anena, and for Pade, we have Dr. Win Michael. I'm seeing our time is up. For Kitgum is Dr. Kenna Jeffrey, who's a pediatrician. For Gulu City, we have Dr. Emmanuel Ochola, who is an epidemiologist and scientific director of Lacho Hospital. We have Dr. Pauline Kijange of Amuru, Dr. Akelo Agnes Oburu, a pediatrician representing Omoro. We have the people who were elected out of the AGM. We have Dr. Tutu Dominic, representing for Noya, Dr. Achan for Gulo District, and he works in a watch, and Dr. Lokol from Long Hospital. So this is the team that will be leading us until 2027. And we really ask for your support and guidance so that what we achieve is a unified goal and service with honor. So at this moment, I've seen we have our 5 minutes is done, and we want to take us back. We take us back to the session, and today we want to answer the question of how ECG can be used in patient care. Yes, we'll be taking us through how ECG can be used in this evolving medicine in patient care, and how can it be used frequently? How do we use it? How do we value it? So we introduce the presenters. We'll be having Dr.
Very deep that they are good. But now you have to reduce, man. I need to.
Win, Michael. Thank you. Please also you reduce your volume. Thank you. I want to introduce the presenter. We have two presenters today. I'll be moderating as of today. And our chair will be the first presenter, Dr. Ribadan. And then we have Dr. Ian Beaton, our visiting senior consultant cardiologist, and while sharing us how we can benefit from ECG. At this moment, Dr. Dan Riba, you're welcome to talk to us.
Thank you very much, Joel, for this wonderful session that you have inspired to be there today. It also reflects the power of our publicity as Acholi Branch. And also, I would like to welcome our dear consultant cardiologist, I think from St. Peter's Hospital. I might have forgotten, but it's from the NHS Trust in the UK, and is doing an amazing job at St. Mary's Hospital, Acholi, especially also in skilling our interns with the point of care cardiology scans, which I think they are all competent in doing bedside cardiology. For the sake of this presentation, I would just kindly ask everyone who is joining to mute so that we have no background interference a lot from you guys. And please share the link to make sure that we have more people joining. Now, I'm just going to run quickly through the basic introduction to EKG. And if you don't understand, I think the cardiologist, Dr. Ian Beaton, will come in with some questions, which I think will help a lot in making sure that you also understand. Now, this is part of our internal medicine presentation that we have also done a lot with Gulu University students. And if they are on the call, they should be having this very simple. I have made over 250 slides, especially for EKG, and another 250, I'm still making them. for all the various topics that are there. So in case of any need in the future, we should be able to have more presentations and skill ourselves on EKG. But for this, I decided that we should start with EKG and also to give a start to our branch in terms of CMEs. And Dr. Ian Beaton will take her through next week on EKGs because he's a cardiologist and we would really love to get a lot from him before he goes back to the UK. And I think even when he goes back, we shall organize sessions on cardiology to host him on. So I think normally I've put this in modules that, you should be able to identify the components of the rhythm strip, identify what components represent the rhythm strip, and of course the criteria for sinus rhythm, and of course criteria for atrial rhythm, and of course AV junctional rhythm. Now this is a little bit comprehensive. Why? Because we had put almost all of them together. But of course, subsequently, when you complete, you should also be able to look at ventricular rhythm, identify rhythm with AV blocks, and also identify those pre-hospital treatment for different cardiac rhythms, which would be very important for all of us to know. So we are going straight to our EKG. Normally, the ECG paper is when you look at it, they say you greet a cardiologist with an EKG paper. When you look at it, sometimes it looks like, something very abstract, but everything on it actually represents something which is very important. And normally at the base of your paper, you look at the speed normally is located like 25 milliseconds. And what are those boxes represent? You find that they are a big box.
Senior, Senior.
Please, can someone mute my colleague over there so that, yes. So you can have one big box, and then inside that one big box, you have smaller boxes, okay? And this one big box here represents 0.2 seconds, and the height of it is 0.5 millivolt. Now, the component of the rhythm strip actually corresponds to, depolarization or electrical activities in the heart. Please, can someone help? If you are the co-host, please be there and muting people who are. Yes, please, can you unmute or can you mute them? Yeah, so all these things that we see here, the P wave, representing for you electrical activity in the atrium, this one electrical activity in the ventricle, and then the relaxation phase of it, and so on. So we need to know how electricity travels in the heart and produce all these waves that are up and down that we see. So the waveform or prolongation of the waveform actually can tell you if there is any block or if there is any problem. So I think it's very important for you to know, the PR segment, which is from the end of P wave, to the beginning of the Q or the R Q wave, and then the P wave, the PR interval, which is very important because prolongation of this can actually tell you there is a first degree block, which is actually the beginning of the P wave up to this level, which is the R, where the R is. So I think it is very important for us to understand this. And then the QT interval, abnormalities of QT intervals are there and can actually manifest in so many ways. And some other drugs can also affect QT. The QRS complex is very important and can tell you about hemi-blocks and blocks like, left bundle branch block, right bundle branch block. Just this distance alone, the QRS complex. And then, of course, the ST segment, which, I mean, every person at the moment talks about ST elevation, myocardial infarction. Much as there is a paradigm shift to nomenclature of this, but for the benefit of this lecture, we are going to be using them. And then T-wave representing repolarization. The J point there, very small, is a point that marked the end of the QRS and the beginning of the ST segment. We have to evaluate the ST segment. It's used mostly for evaluation of ST segment elevation, which is probably 0.04, which is just one small bulk after the J point. And the relationship to the baseline, of course, when you're assessing the J point, it tells you so much of still also electrical activity, if probably there's any ischemia or not there. And I think Dr. Ian will talk about them in the subsequent examples. The intervals and the complex, PR intervals is a trio and nodal activity. So depolarization and of course delay in the AV node is represented in the PR segment. And of course, the QRS complex correspond to the patient's palpated pulse. When you palpate the patient pulse, you are actually getting the deflection of the QRS complex. It's large in size due to reflection of the ventricular activity, which also corresponds to the ventricular mass. So this is our details of all this. I mean, the RR interval from one RR to the next RR, that gives you the, it's used for calculation of the heart rate, very important as well. And also to check if there is any RR abnormalities and all this. I mean, the normal ranges of it, PR should be between 0.12 to 0.2. I mean, it shouldn't be bigger than one big box like this, okay? The PR interval should not be bigger than one big box. And then the QRS complex should not, is normally 1 to 3 small boxes. And when it is probably more than that, then you start thinking about hemiblocks and other things. The QT interval that you see here normally is corrected because it can be affected by the rate. And so you are interval, the square root of RR interval. So you calculate this QT from here up to here, and then you divide by the square root of R main and female. Interpret it and say this is prolonged QT interval. This is borderline. This is a sinusoidal node, and electricity travels from here, and then it comes here via the east Parking. Then others, of course, in the left bundle you have some small fascicles which are nating into the Purkinje. I think we can see from these animations, I mean, it's just telling you what is happening, using for you the P wave. The whole thing, you assign a trio node, atrial depolarization producing your P wave. At the AV node, some small delay, you get a Q, and then depolarization of the ventricle, you get the QRS, and then there is contraction, and then relaxation because of, changes which are now normalized. So augmented leads, precordial leads, and then the limb leads. But of course, about it, you need to know how to put it on the patient and read it out. And lead number 3 is pointing downwards, and lead number 2 between. So this just also because that it lies and look probably on the heart in the transverse plane. And I think Dr. Ian will say anything again about it if there's anything to add. So this is the AVR when you put on the patient, and this is the AVL that you put on the patient, and this is the AVF that you put on the patient. When you look at this circle here, this one here, and then you put the lead 3 and lead 2 here, this brings for you the nth Venn triangle, which I think we are going to use a lot for calculation of either left axis, physiological left axis, normal axis, and then right axis, then extreme axis, that sometimes they say indeterminate axis. Now, all limb leads, not that the direction in which they are looking at the heart. You can see this is the right atrium, this is the right ventricle, this is the left ventricle. You can see when you want to look at, you see, AVL looks at the left ventricle in this point, and lead 1 looks at the left ventricle. That's why when left axis, probably they say, okay, left ventricular hypertrophy. They are looking at this. They will place the heart in this plane. And then, of course, AVR, and then lead 3. They are looking at the heart from this position. And when you look at lead 2, lead AVF and lead 3, this looks at the heart in the inferior point. So the left side of the heart, lead 1 and lead 2, looks at it. Inferior side of the heart is lead 2, lead 3, and lead AVF. So when you're also looking at myocardial ischemia, you say, okay, is this inferior myocardial ischemia? Whoever is looking is asking you, probably is looking at what are the changes happening in lead 2, lead 3, what are the changes happening in lead AVF, and what are the changes happening in lead 2. So these changes are supposed to be contiguous. Whatever is happening in lead 2 should be similar to that is lead AVF and lead 3. So the put in the 4th intercostal space, intercostal space, left sternal border, and then of course V3 put between V2 and V4, and then of course V4 is in the 5th intercostal space, mid clavicular, actually at the apex of the heart, and then V5 put in the intercostal space, anterior axillary line, and then V6 put in the 5th intercostal space, mid anterior axillary line. That is how you put these leads. And so all the leads, when you have represented it, you find that the right is here, the left is here, and then the AVF, which is foot, is here. And all this bringing for you the nth Venn triangle, which tells you that lead 1, summation of forces in lead 1, lead 3, and lead 1 is equals to 2. And all this will tell you that whatever is happening here, this left axis, it's left axis, but it is physiological. So this is normal axis, and then this is right axis, and then this is extreme axis or indeterminate axis. We are going to look at how to determine this axis. So anatomical grouping. When you look at lead number 1 and AVL, it is looking at the lateral aspect of the heart, and also V5 and V6. So if you have a lateral myocardial ischemia, okay, you are looking at this, and then you can go to the different anatomical vascular supply. When you are looking at inferior wall myocardial infarction, you are looking at lead 2, lead 3, and AVF. This is very important. And once you understand the nth Venn triangle, this comes out very clearly. And then, of course, AVR is very none, really. And then V1 is septal, V2 is septal, then V3 and V4 are anterior. So if you have septal ischemia, you will see changes in V1, V2. When you have anterior wall myocardial ischemia, you will see changes in V3 and V5. And then, of course, posterior is not represented here, but it's a reversal of those. And so this is a normal ECG. Why do we say it's a normal ECG? Look at this P wave. The P wave is positive in lead 1. The P wave is positive in lead 2. It's positive in lead 3 and AVF. So this is a sinus rhythm because the P wave axis is positive in lead 1, lead 2, lead 3, and AVF. Whatever is coming, the information that is coming from the sinus node. And of course, for every P wave, there is a QRS complex. There is a QRS complex. It's a 1-to-1. And then there is a normal T wave there, and the QRS is also normal. So this is how a normal ECG looks like. So if you are interpreting an ECG, normally I've put this as the 10 rule of Professor Chamberlain's. I mean, it's not between 3 to 5 small squares. Are you still getting me? Yeah, should not be less than 3 small squares. And I think you guys will go over this again. Just read about the 10 rules of the Chamberlain 10 rules. It's very well illustrated also in Life in the First Lane for training you on ECG. How do we get access? So that I invite Dr. Ian to come very fast, because I think I'm left with very few minutes. I want to give him more time as a cardiologist too. When you want to get access, I mean, axes are very important, especially QRS complexes tells you where the axis is. So, I mean, it can tell you, if the QRS can tell you ventricular enlargement on top of telling you where the axis is, and then can also tell you conduction blocks or EMI blocks, which are there. So when you see this diagram here, it tells you either left axis, normal axis, right axis, indeterminate, that sometimes we call extreme axis deviation. And by consensus, that is what it is. But just simple. I normally use 2 methods for determination of axis. And I think I have to write it here. Normally, when you have, there is what we call the quadrant approach, and then the equiphasic approach. Predominantly positive, predominantly negative, but you look at the one which is equidistant, such that the summation of forces here to the summation of forces here is almost equals to 0. So the quadrant approach is very important. And I think examine the QRS complex in lead 1 and AVF to determine if they're positive. So here you look at lead 1. If you're looking at the quadrant approach, look at lead 1 and lead AVF. So if the deflection in lead 1 is like this, and then the deflection in lead AVF is like this, means when you consider this diagram here, I'm going to draw this once and for all, where we say this is AVF. No, this is lead 1. Okay, this is AV foot. Let me just put foot. This one here is lead AVL. Okay, this is lead AVR. And then, of course, this is lead number 2. And then, of course, this is lead number 3. Okay, so this one, put dash there. There's a dash here. This is how normal it is. So we said we look at lead 1, which is here, and then lead AVF. So if lead 1 is positive, positive means it's traveling in this direction and the deflection is positive, and lead AVF is also having a positive deflection, means the resultant force is going down. So this, when you check this and that, the resultant force will be here. So this is normal axis. Normal axis is like dating. You are all moving in the same direction. You're all having similar goals, but you're not meeting as husband and wife. You're not yet migrated in the house. So this is equals to dating. Okay. So let us look at right axis. Right axis, I normally equals to, marriage. People come together in right axis. So in right axis, you lead number 1. Okay. And then lead number 2, no, AVF. So you see, when you come here to lead number 1, last one it was engaged. So the man decides, say, okay, let us move in together, get married. So here you find that this is AVF. Lead number 1 is moving in that direction instead of this one. The AVF maintains its position, which is here, by deflecting up. So here it occupies right axis. Okay. So the resultant force is falling here. Now we look at left axis. In left axis is equivalent to divorce. The one who moved in said, I'm going to move backwards. Okay, let me go back to my initial position. And then also the one who moved here, you remember the AVF, this one here, which was also moving up, said, let me also move up. Let me move down. We all move in our separate direction. You see this QRS is pointing reverse direction to that one. So this left axis is equivalent to divorce. They were initially together, then they just decided to change because they were not compatible anymore. So here you find that the QRS complex, in lead number 1, it's in no normal direction. You see it's moving upward, so it remains its normal direction. But the AVF is now moving in the reverse direction, which occupies here. So this area here becomes left axis. So left axis equal to divorce, then right axis equals to marriage or staying together, and then normal axis, it's a dating. That's how simple it is to summarize the quadrant approach. And the example is here, you can see in lead number 1, okay, this is probably lead number 1 is going downwards, predominantly down. AVF is going up. You look at what is happening in lead number 2, okay? Lead 1 is negative, positive in lead 2, okay? So this is negative in that direction. Then this is occupying right axis deviation. And then the quadrant approach in this one here also, you can see this one is going up. So the direction of impulse is there. And then AVF is going down. So it is negative deflected, okay? Okay, so this is actually, it should have been left axis deviation, but because in lead number 2, it is positive, predominantly positive. This is what I said, actually, it is physiological left axis deviation, which is actually normal. It's non-pathological. The true left axis is very small, which is like in this one here, whereby even in 2, sorry, I've not put 1 like that. So if you have a true left axis deviation, even lead 2 has to be negative, not positive. Equiphasic, we are not going to mention anything about it. So I want to pass over this so that Dr. Ian can now take us through. Be systematic when interpreting the ECG. Look at the rhythm axis intervals, chamber hypertrophy, if there are any ischemia. And here you look at the rule of 300 when they are determining the heart rate, that from here up to here, 300. Then you divide 1, this is 1, 2 big box, then plus this, plus that gives you 3. So 300 divided by 3, you get 100 beats per minute. But this is a table which summarizes for you. 1 big box is equivalent to 300 beats per minute. 2 big box of QRS occupying both is 150. 3 is 100. But what about this? What is the heart rate here then? You consider the RR interval of this patient and you measure this. So you count 1, 2, 3, 4, 5, 6. So 300 divided by 6, you get 50, which is your beats per minute. This works for regular rhythm, okay? The 10-second rule, most ECGs are actually in 10 seconds. But if they are not in 10 seconds, how do you know that they are in 10 seconds? You count all the small box squares that are there occupied by the ECG, and then you multiply it by 0.2, okay? If you multiply it by 0.2, it should be able to give you either 10 or 6-second rhythm, and you can know it like that. So what is the rate here? This is an irregular rhythm. You just count the RR. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 times 6, since it's a 10-second rhythm. So this is 72 beats per minute. This is good for a regular rhythm, okay? You calculate in the rhythm analysis, calculate the rate here, 9 times 10, you count 1, 2, 3, 4, 5, 6, 7, 8, 9, okay? You multiply by 10, 90 beats per minute. Determine irregularity. Irregularity is from error to error. The distance must be equidistant. And if you are in an exams or an hospice, the examiner has to see you tracing this so that at least 3 or 4 successive ones. And then assess the P wave. Look at the P wave morphology. It can tell you if there is atrial enlargement or abnormal, right heart hypertension or pulmonary hypertension or even COPD. You can see it from there really in the P wave. Determine the PR interval from here. Like we said, the PR interval should not be bigger than 1 box like this. So from the beginning of this P up to here, it should be less than 1 big box or just at most 1 big box. And then determine the QRS duration, which is here. Okay. So here, regularity RR interval is normal. So this is a regular rhythm because they are equidistant, okay? And occasionally irregular, regularly irregular, irregularly irregular. All those are possibilities. So this is regular. Assess the P waves. The P waves are actually occurring before every QRS complex. And the P waves are normal. Do they look alike? Because in multifocal atrial tachycardia or MAT, you have different morphology of P waves. And do they occur at regular pattern? So that you know that, okay, the P wave is either coming early or late. And that one can tell you about first degree, second degree blocks of the heart. Is there a P wave before every QRS complex? Interpretation here, these are normal P wave with the 1 P wave for every QRS complex. Determine the PR interval. Here the PR interval looks to be 0.12. Let me see, 3 to 5 boxes small. Interpretation here, 1, 2, 1, 2, 3, 4. 4, I think, comes to about 0.14 seconds. QRS duration. The QRS duration here is really very small. I think there are 2 boxes, you're occupying 2 boxes. So this is 0.08 seconds, which is normal. Rhythm's primary here is that we have 90 beats per minute. It's a regular rhythm. Its P waves are normal. The PR interval is 0.12. The QRS duration is normal. Interpretation, normal sinus rhythm. And this is how you are supposed to interpret an ECG. At this point in time, I think I'm going to give time for Dr. Ian Dr. Ian Beaton to take us through the questions. Then we have discussion.
Thank you very much, Dr. Dan. And just to give you a bit of background to myself, I'm Ian Beaton. I'm often mistaken for Ian Clark. I've never met him, but I think he's a very famous Ian in Uganda, and I don't mind being mistaken for him. I've been hosted by Dr. Dan and the medical team at St. Mary's La Chaux for 2.5 months now, and I'm very pleased to be here. I think questions is a good idea. And then for next week, I have an ECG quiz. We don't want this to go on too late tonight because it's Saturday night and it's time for you to have fun. So I think questions, and then just to say that there should be an ECG quiz next week. And there's 2 ways of learning, of course, and you need to use both ways. There's the theory, which Dr. Dan gave you very well there. But also to have fun, you need the actual cases. And little by little, the theory and the fun of patient work comes together, and you get a complete knowledge of ECGs that could benefit you and make your job enjoyable. So any questions, I'd be very, very happy to try and answer them.
I think at this point in time, Joel, you can take over. I think Dr. Ian will be leading us in the question and answers. Of course, I think the audience is probably rich with the questions and answers, questions that should be coming in. Please, you moderate this session, and Dr. Ian will be able to answer them. I think the next presentation will be having the quiz, as he has told us, and that is next Saturday, the same time, 6 to 7 p.m. Is that okay, Dr. Ian?
That's absolutely fine.
No, Dr. Beaton. Yeah. I don't know why today I'm calling you Ian.
It is my name, so it's not confusing. That's all right.
That's okay.
Yes. Yeah. So if there aren't any questions, oh, here we go. How to calculate the atrial rate and the ventricular rate. So as Dr. Dan said, that the way that we mostly use with ventricular, with regular rhythms, provided the atria are firing, so it would be, in sinus rhythm, but also in heart block, the atria will be firing as well, is we
Recording
take
in progress.
the number of large squares between each complex and divide it into 300. So we're calculating the atrial rates and the ventricular rate, it uses the similar theory. But so let's say it's sinus rhythm, and if there's sinus rhythm, the PP interval, so that's the time between each P wave, will be the same as the RR interval. So let's say it's 5 large squares. That's 5 large squares into 300 will give you the number of 60. But the important thing is, if you start seeing heart blocks, and just a spoiler alert, there will be a heart block in next week's quiz. So just remember that. Of course, when you calculate the PP rate, the atrial rate, it will be twice the ventricular rate. So it's really important when you look at a patient who has bradycardia, even a mild bradycardia, like under 60, to look at the PP interval and the RR interval. But it's using the same method, but you have to look at the P waves, and you have to make sure that there are the same number of P waves as there are R waves. And when there isn't, you know that there's an arrhythmia. And next week, there'll be lots of examples where there are many more P waves and QRS complexes. So, that is the way of doing it. So there's another question. Dr. Dan, great presentation. Is it possible? Oh, okay. So Dr. Bonica says, what do we really mean by axis, like deviation? So what we mean about axis is the major electrical deflection of the heart. So the heart is an electrical structure, like a magnet in our chest with a positive and negative pole. And so we're looking at the major electrical deflection through the heart of the QRS complexes. And so as Dr. Dan said, the normal axis is somewhere between -30. So from 0 to -30 is called physiological left axis deviation. So that's normal up to 90 degrees. And that means that the electrical axis of the heart is going somewhere between here and down here. And that's just an indicator of the cardiac position and also the electrical conduction through the heart. So it's a combination of the position of the heart and the direction of electrical flow. So if you have blocks like a left bundle branch block or a left hemi block, then electricity path will be deviated and you'll get axis deviation. And if you have major cardiac morphological abnormalities, like you get with congenital heart disease, you'll get cardiac axis deviation. Now, I would suggest to you that you don't stress yourself too much regarding axis and what it actually means, because axis is a screening tool. So you use it for a patient who comes to you with possible cardiac symptoms. And if the axis is normal and the ECG in other respects is normal and the clinical examination is normal, then you look elsewhere to see whether the symptoms are due to cardiac disease or not. And you listen to the heart and you do other examinations. Whereas if the axis is abnormal, then you think, even if my clinical examination is normal and this doesn't really seem to be a cardiac issue, I should look further. So, in the modern world, those are the patients in whom we would just say, well, do an echocardiogram. So it's it's more a screening aspect. So if you can't get your head around axis, I wouldn't get too worried about it. If it's abnormal, and medicine is more than just looking at numbers. If the axis is abnormal and examining the patient is abnormal, or the history is suggestive of cardiac disease, then you just need to look further for an echocardiogram. So if you can't get your head around axis, don't worry too much. So there may
Yes.
be some other questions, but I just carried on talking. I'm sorry about that.
Please, you can continue with the questions, Doctor. Yeah.
So are there any questions I
No, I
didn't
think
pick up there?
talk about the J point and ST elevation. I think
Okay.
Dr. Enol
Okay.
wants to understand something on it, Doctor.
Yes. Okay. So ST segment elevation is obviously generally taken as being a very worrying sign, but there are some patients who have normal variant ST segment elevation. There's some patients who've got pericarditis, and there's some patients who have got bundle branch block. And then, of course, they're the most worrying patients who have ST segment elevation myocardial infarction. So the way of picking this up is two methods. The first method is to use old-fashioned medicine. So if someone is, presenting for, just a hypertension checkup, and they're displaying ST segment elevation, and they've walked in with no pain and no concerns, well, you should start being concerned that actually that ST segment elevation is probably not an indicator that so especially in Africa, and especially young men will have a J point elevation we call early repolarization pattern, and that will be present and sometimes in V4, even in some athletically trained individuals. And so what you get is you get J point elevation, and then the ST segment goes flat until it reaches the T wave to indicate a cardiac repolarization. And those patients, they'll be a classical type of person. So often a young Black or Afro-Caribbean man will have this early repolarization pattern, and that's where there's some J point elevation, but the ST doesn't carry on going up. Then there's the pattern of pericarditis, which is classically called saddle shaped, like a saddle on a horse. And we call that concave. So it's sort of a down and then up, as opposed to convex, where you've got this tombstoning appearance like you get
with also put that
infarction.
in the coming ECGs, because we have so many ECGs that people would benefit from. And these are directly from patients. I think it's real clinical cases, yes. And I think very important. What you have said about J point and of course benign early repolarization, I've received so many ECGs that sometimes send to me that, oh, this is ST segment myocardial infarction. Then when you go into details of it, you find that, okay, this is V2, V3. Could this be just, there are no any other contiguous changes, no much symptoms in these patients. So it's very typical for benign early repolarization to be confused with a ST segment elevation myocardial infarction, which I think you have mentioned clearly. Plus, yes. Of course, other differentials of pericarditis that you have put. Doctor, there are some other questions again. Yes. I'm going to be a little bit quiet because I think you're here. I will just answer this one directly. Dr. Jasper Vumbi, please, subsequently, you will understand how to differentiate between atrioventricular nodal reentry tachycardia from atrioventricular reentry tachycardia. Those are forms of SVT, which I think Dr. Ian Beaton will tell you next time if we cover it up. We'll just follow up the series. We shall change the link maybe to the official UMA link if this is not available. And then, Dr. Howane Joshua Henry is asking, what do the terms regular, irregular, and irregular means, and what are their significance? Then I think Kawesi Regan is saying, Doctor, thank you for the presentation. T-wave changes on the ECG with no cardiac symptoms significant. I think you can start with those two, and give us your...
So the terms irregularly irregular is a description of a cardiac rhythm where really it is chaotic. And the way I say it is if you're listening to music it is the kind of music that you would say you hear in a jazz club. It's just, there's no clear way of predicting where the next beat will come from. So an irregular rhythm is completely chaotic, and you cannot predict where the next QRS complex is going to be heard or palpated. And that's classical of atrial fibrillation. Now, a regular irregular rhythm, and we've got a few of those next week, is when you have the RR interval is variable, but when you listen to the heart for long enough, then you can pick up that there is a pattern. And that happens in two situations. One is a Wenckebach rhythm, which is a type of heart block where you have progressive prolongation of the PR interval until a beat is dropped. And so what you notice then is you notice a gradually increasing time between each QRS complex, or between each heartbeat, and then a gap. And then that pattern recurs. So that's with Wenckebach. And the other situation, which is much more common, I would say, is patients with atrial and ventricular ectopics, when they have one ventricular or atrial ectopic every 2 or 3 beats. And so you go dump, 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 and then a pause, dump, 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 and then a pause. And so I believe I have some examples of those next week, which I can show you. But that's, and so it means the rhythm isn't completely regular, but there is a regularity to it. And the main feature there really is to make sure that you diagnose atrial fibrillation correctly, and they would be irregular. And it's more useful for patients who haven't had ECGs. So, it's more for clinical practice. Before it used to be very difficult to do an ECG. The other question was, just remind me, Dr. Reba, the other question. Your microphone, Dr. Reba.
I think it's in the chart. I think it's about the significance of the T wave. Can you try to read it?
Okay. Yes. Sorry, you're quite right. No, I had my chat turned off. I'm sorry about that. So T-wave inversions. So T-wave inversions is a major source of employment for cardiologists. So if you become a cardiologist, you can buy a house with T-wave inversions, because it's a major cause of concern. Now, it's a case of the T-wave would usually follow the major QRS deflection. So if you have an upward facing QRS complex, like Dr. Dan showed us, is a positive deflection in the QRS complex, you will normally expect the T-wave to be in the same direction. So a positive QRS complex usually results in a positive T-wave. So that's a general rule of thumb. If you look across an ECG, and that generally will follow. So if that is happening, then generally if you've got a negative, like very, very many people, especially as one gets older and a bit fatter, the inferior leads become inverted as the diaphragm pushes up on the heart. And so you have inverted QRS complexes, and the T waves are inverted inferiorly. So that's usually inferior T-wave inversion, is, provided the QRS complexes are also negative, is a benign phenomenon. The main concern regarding T-wave inversions, and if I were to give you a basic rule of when to be concerned, I would be concerned if there's T-wave inversion in AVL and in leads V5 and V6. So those are the ones to really worry about: AVL, V5, and V6. So if you've got a patient and they've got T-wave inversions in those leads, then they need further investigations. For the other ones, I would use your doctoring skills to decide whether the person seems ill enough, and also look at the degree of T-wave inversion. Is it really deep T-wave inversion? But the bad ones are AVL, V5, and V6. And if you remember that, I think you won't miss people with major cardiac pathology.
Thank you very much, Dr. Ian. I know you're really very comprehensive when it comes to ECG, and the next one will be really interesting, because we don't want you to be interpreting ECG in the air. We want to see the real
Yes.
real patient case basis, and you can also attach some ECGs like we have been doing during our weekly trainings. Going forward,
Yes.
I think I have Dr. Brian Serumaga. In the ICU patient with DKA, we tend to get pseudo hyperkalemia. Dr. Brian, when you get pseudo hyperkalemia, it's a lab evaluation error because they might have taken time to analyze that blood sample, and so it's not a true hyperkalemia. So it won't show on ECG if it is not true hyperkalemia. So please just take it like that and make sure that you analyze your blood samples earlier on to prevent confusing and treating these patients with DKA, thinking they are hyperkalemic, yet actually in DKA, they're likely going to be hypokalemic because of insulin transit of potassium. I think, James, you have put it clearly. Can the rule of 1,500 divide by number of small boxes between RR for irregular sign work for calculating heart rate? This is Wanani NASA. I have never had this. I've not had this. It looks to be very new to me, Dr. Ian, but Dr. Beaton. But
yeah,
if you knew anything about it, you can tell us. I've never had a rule of 1,500.
I think that's for the very small squares, which are obviously will be 5 times. So you'd spend
more time.
You'd spend a lot of time. But yes, I believe that would yes, if you count the number of small squares and divide it into 1,500, that should also work. I've not used that myself.
Okay.
Yeah.
Okay. I think going forward, I think most of the questions we have answered, and we are on top of the hour. We have really managed time. Dr. Joel Ochora, I would like to give this back to you. If there are no any other questions on the chat, maybe we set pace for the next session. Dr. Ian, we are very happy to have you, and this is also part of it to introduce you to our Ugandan team and other people. I'm very sure the work that you're doing at St. Mary's Hospital Acholi is enormous. And thank you also for the donation of a bedside Clavret ultrasound scan, which is revolutionizing our practice of cardiology, bedside cardiology in the hospital. So really, we are very grateful for your coming here and also to teach. Going forward, we shall also give you some sessions with Gulu University students to make sure that you skill them up very well. And I give the mic back to Dr. Ochora Joel. But before I do that, let Dr. Ian give us his last vote of thanks.
Yes, well, thank you very much for hosting me. And I must say, I think that ECGs are a very elegant tool for patient evaluation, because the patients are giving the electricity to us. It's not like we have to shine radiation or ultrasound or a magnetic field into them. It's electricity that they're giving to us, and we're just measuring it. So it would simply be rude not to measure this electricity that our patients are giving us. And so I think it's an extremely elegant technique, and we all should be able to have some idea of our approach to ECGs. So thank you so much.
Thank you, Doctor. Over to you, Dr. Joel. Well, can we see you?
Thank you. Yes, you want to see me? All right.
Yes, yes, yes.
Welcome back to The Explainer. Okay, picture this. You're walking down a brightly lit hospital corridor. Your heart is literally pounding in your chest. You're about to walk into a high-stakes clinical exam room, the dreaded OSCE. Today, we're going to master exactly what happens when you step through that door and face the ascites patient station. Think of me as your mentor today, because we're going to walk through the exact steps you need to absolutely conquer the scenario.
So here is our game plan for the simulation. First, the examiner's instructions, then avoiding common exam pitfalls, presenting your findings, surviving the rapid-fire Q&A, and finally, patient management strategies.
All right, let's dive into part 1, the examiner's instructions. You've just walked into the room. The examiner is sitting there, staring right at you, and the tension is totally palpable. And then they hit you with this prompt. This lady complains of abdominal discomfort. Please examine her abdomen. It sounds so simple, right? But recognizing what this specific, anxiety-inducing instruction actually means is your crucial first step. They aren't just asking for a basic belly rub. They're cueing you to look for a really complex set of systemic signs related to fluid accumulation. Let's move right along to part 2, avoiding common exam pitfalls. You've got to pay close attention here, because falling into these physical exam traps will cost you dearly. Using an improper technique for shifting dullness, that's a classic rookie mistake. So is completely missing coexisting organomegaly. But I really want to emphasize that third point, missing the stigmata of chronic liver disease, things like spider nevi or palmar erythema, that is a guaranteed way to bleed points. And finally, under the intense pressure of the exam, a lot of candidates completely blank on the causes of ascites when the patient doesn't have any leg edema. Okay, part 3, presenting your findings. So, the physical exam is over, you've washed your hands, and it's showtime. You're dealing with a clinical reality like a markedly distended abdomen, classic ascites. Grounding all our theory in this physical presentation is key, but how do you actually translate that visual into the perfect verbal pitch to the examiner? I want you to internalize this exact professional phrasing. You look the examiner in the eye, and you say, "This pleasant lady appears cachectic and pale. Examination of the abdomen revealed a positive shifting dullness but no organomegaly. There is no pedal edema and no stigmata of chronic liver disease. The deduction happening here is just phenomenal. By clearly stating there's ascites with anemia but no pedal edema, you're elegantly pointing them straight toward a neoplastic process or maybe abdominal tuberculosis. You're showing them you're already thinking 2 steps ahead." Now for part 4, the rapid-fire Q&A. Take a deep breath because this notoriously stressful grilling is about to begin. The examiner leans in, clipboard ready, and asks, what causes ascites without pitting edema? Let's test your active recall right now. What's your answer? Notice how beautifully categorized this differential diagnosis is. It takes a complex physiological distinction and makes it incredibly easy to memorize. If there is no pitting edema, boom, you immediately list malignancy, tuberculosis, and constrictive pericarditis. But if there is pitting edema, your mind should jump straight to congestive heart failure, nephrotic syndrome, and liver cirrhosis. Having this split memorized will completely save you. They aren't going to let up, though. Now they want physiology. The next question, what is the portal venous pressure at which ascites starts to develop? Greater than 12 millimeters of mercury. You've got to drop this hard metric, aggressively and confidently. Knowing specific numbers like this is exactly what separates the standard passing candidate from the truly exceptional one. And then comes the classic follow-up, just to test your knowledge of the physical exam's limitations. How much fluid is actually needed to detect shifting dullness clinically? You literally just performed it, but what's the threshold? You need more than 500 milliliters. It's kind of wild, right? While shifting dullness is one of the most sensitive signs we have, it's present in about 90% of cases, it still requires a massive half-liter of fluid sloshing around in the peritoneal space to actually be detectable. Just when you think you're safe, they hit you with this. Do you know any other technique to detect ascites clinically if the fluid is less than 500 milliliters? Listen closely, because this is the insider tip. This is the exact question examiners use to identify their top-tier candidates. This is where you pull out the obscure but totally fascinating puddle sign. You confidently describe how a puddle is just a small collection of water. Tell the examiner you'd have the patient stay in a prone position for a few minutes and then raise themselves onto their elbows and knees. When you percuss the flanks, it yields a resonant note. But when you percuss the dependent center of the abdomen where that tiny puddle of fluid is gathered, it yields a dull note. The real kicker here, the puddle sign can detect fluid amounts as incredibly small as 120 milliliters. Just make sure you remind the examiner that while it catches tiny amounts, it actually has very low overall sensitivity. All right, we're transitioning to the final stage of the examiner's grilling. They pivot from diagnosis to advanced clinical prognosis, asking, what are the most reliable signs that determine the prognosis of cirrhotic patients with ascites? You just calmly walk them through these 4 grim prognostic indicators: the presence of hyponatremia, low arterial pressure, increased serum creatinine, and low urine sodium. Highlight for them how all of these signs together paint a cohesive, terrifying picture of failing hemodynamics and severely compromised kidney function. Finally, Part 5, Patient Management Strategies. Okay, you can release the tension of the Q&A. It is time to wrap up the clinical encounter by shifting your mindset into the actionable steps of a practicing physician. Guide the examiner through a logical management plan. Start with a proper history for etiology, checking for transfusions, drug use, or old TB. An abdominal ultrasound. Next, request bloods, specifically CBC, LFTs, urea, and electrolytes, along with urine protein. And definitely stress that step 4, a systematic approach to paracentesis fluid analysis, looking at cell count, albumin, and that crucial SAG, is the ultimate key to finalizing your diagnosis. And with that solid management plan, you've conquered the station. You've mastered the physical signs, numbers cold. But I'll leave you with this final thought. When the examiner stares you down in that quiet room, can you confidently defend your differential diagnosis under pressure? Actively practice your verbal presentation using this explainer until it becomes absolute second nature. Keep practicing and go crush those exams. All right, let's jump right into this explainer. Today, we're basically turning things into a realistic hospital ward setting to help you completely conquer high-stakes cardiovascular clinical exams, like PACEs and the OSCE-E. Look, if you're gearing up for these exams, you already know the medical theory, right? But applying it flawlessly, under the intense, watchful eye of an examiner, well, that's just a completely different ballgame. The source material hits us right out of the gate with a pretty sobering reality check. With PACE's exam pass rates sometimes dipping below 50%, systematic, daily preparation is absolutely your greatest weapon. It's really not just about what you know in your head, it's about how clearly and how confidently you can demonstrate that knowledge at the bedside. Stepping into a clinical exam is literally like stepping into battle, and your preparation, that's how you win. So here's our game plan to get you ready. We're going to walk step by step through the ultimate checklist. Section 1 is the clinical exam approach. Section 2, initial cardiovascular inspection. Section 3, valvular heart diseases. Section 4, hypertrophic cardiomyopathy. And we'll wrap up with Section 5, atrial fibrillation and heart failure. Starting things off with Sections 1 and 2, approach and initial inspection. Listen, the absolute most crucial point before you even think about touching the patient or reaching for your stethoscope is establishing a highly professional approach. First impressions dictate the entire tone of the exam. Before any of the complex diagnostic stuff begins, the examiner is waiting to see you execute 4 non-negotiable steps flawlessly. Wash your hands. Introduce yourself and actually get permission. Position the patient perfectly at a 45-degree angle, because you'll need that to properly assess the jugular venous pressure later. And finally, warn the patient to let you know if any discomfort happens. Missing these basic steps is an unforced error you simply cannot afford to make. And this is exactly why your general inspection is so critical. Before you ever listen to the heart, you've got to look closely for clues. Spotting a median sternotomy scar right away, that literally tells you a whole story about the patient's surgical history, maybe a previous coronary artery bypass or valve replacement. If you just jump straight to auscultation, you might completely miss the entire context of what's going on with the patient. You've also got to keep your eyes peeled for structural anomalies, like pectus excavatum, that sunken chest appearance. Why? Well, spotting these visual clues early stops you from getting blindsided later in the exam. An abnormally shaped chest can actually physically displace the apex beat. Knowing that in advance keeps your entire examination smooth, logical, and confident. All right, moving right along to Section 3, valvular heart diseases. Once you move to specific stations, valvular heart diseases is a classic area where examiners love to relentlessly test your clinical acumen. They want to see if you can synthesize multiple physical signs into one unified diagnosis. Take mitral stenosis, for example. Unprepared candidates frequently fall into the trap of missing coexistent atrial fibrillation, or they completely forget to check the hands for signs of infective endocarditis. A forewarned candidate, though, they perfectly present the typical physical findings: a tapping apex beat, a loud first heart sound, an opening snap, and that classic mid-diastolic rumbling murmur. And hey, a truly top-tier candidate will also immediately state they'd want to run an ECG to look for that super common complication of atrial fibrillation.
So picture this. The examiner leans in, looks right at you, and drops this precise question to test the depth of your knowledge. They don't just want to know if you can hear the murmur. They want to know if you truly understand the hemodynamics happening inside that patient's heart.
Your answer needs to be a rapid-fire reflex. You must cover these 4 key clinical and echocardiographic severity indicators without even blinking. First, the shorter the interval between the second heart sound and the opening snap, the more severe the stenosis. Boom. Next, you want to mention looking for clinical signs of pulmonary hypertension. Then, note the length of the mid-diastolic murmur. And finally, cite an echocardiogram finding of a valve area less than 1.5 square centimeters. That's how you nail it. Okay, let's pivot over to section 4, hypertrophic cardiomyopathy. This one is a massive trap. Hypertrophic cardiomyopathy, or HCM, is one of the most commonly confused cardiovascular conditions on the ward. It is so easy to misdiagnose it as aortic stenosis because, well, they both present with an ejection systolic murmur. When the examiner asks you to differentiate the two clinically without relying on any imaging, you have to explain that the HCM murmur is loudest at the left lower sternal border and does not radiate to the neck, which is the complete opposite of aortic stenosis. Crucially, tell them you'd ask the patient to perform the Valsalva maneuver. The HCM murmur gets louder while AS gets softer. Finally, you palpate carefully, right? Because HCM features a really unique double apex beat, whereas AS presents with a sustained heaving impulse. But you can't just stop at the physical exam. You've got to be ready for the underlying science too. A great candidate confidently explains that HCM is primarily a genetic defect of the cardiac sarcomere, often passed down as an autosomal dominant trait. And to secure those absolute top marks, you should outline a management plan that heavily involves ECG and Holter monitoring, because sudden cardiac death from ventricular arrhythmias is a huge risk for HCM patients. Explaining exactly how you'd use the ECG to look for left ventricular hypertrophy and dangerous rhythm disturbances shows some serious clinical maturity. And that brings us to our final stretch, section 5, atrial fibrillation and heart failure. These topics are incredibly common on the wards, and they are practically guaranteed to show up in your clinical exams. An examiner asking you to rattle off the common causes of AF, that is a classic pressure cooker prompt. It can make even a well-prepared candidate draw a complete blank. When the adrenaline is pumping, it is remarkably easy to forget a simple list of causes. To keep you from freezing up, the source material hands us this absolute lifesaver, the Matches mnemonic. It's an incredibly easy anchor to perfectly list the causes of AF under pressure: mitral stenosis, alcohol, thyrotoxicosis, coronary artery disease, hypertension, and sleep apnea. You'll totally impress the examiner by reciting this smoothly, and then noting that to manage these patients properly, performing a 12-lead ECG or Holter monitoring is your very first investigative step to officially document that irregular rhythm. Now, a quick word of warning here. You must be able to precisely define the subtypes of atrial fibrillation. Loosely throwing around terms like paroxysmal and persistent, as if they're interchangeable, is a major red flag for examiners. Just remember the rule of 7 days. If the AF terminates within 7 days, whether that's on its own or through some medical intervention, it is paroxysmal. If it lasts longer than 7 days, it's categorized as persistent. Precision in your terminology proves to them that you are truly ready for specialist practice. Shifting gears to heart failure. The examiner's goal here is to see if you can untangle a messy clinical picture. Can you cleanly separate pure right-sided failure from pure left-sided failure? For the right side, you're basically looking for systemic congestion, an elevated JVP, tender pulsatile hepatomegaly, and leg edema. For the left side, the fluid backs up into the lungs, so you're hunting for orthopnea, an S3 gallop, and bibazilla crackles. Conflating these signs? Yeah, that just shows a lack of deep fundamental understanding. Furthermore, you've absolutely got to understand the ejection fraction split. Literally up to 50% of all clinical heart failure presentations are actually heart failure with preserved ejection fraction, or HFpF. That's typically driven by a stiff ventricle from long-standing hypertension. And this is completely different from reduced ejection fraction, which is treated aggressively with medications like ACE inhibitors and beta blockers. And hey, for those reduced ejection fraction patients, you would also scrutinize their ECG for a left bundle branch block with a wide QRS complex, because that would indicate they might actually be a candidate for cardiac resynchronization therapy. Finally, when standard medical therapy just isn't cutting it for severe heart failure, examiners want to see if you can identify advanced physical signs and interventions. If you walk up to a patient and see a setup like this, you need to recognize it instantly as a left ventricular assist device, or LVAD. It's a mechanical pump used for patients with a really low ejection fraction, below 25%, often serving as a critical bridge to a heart transplant, or even as destination therapy itself. So, as you wrap your head around your notes tonight and envision stepping onto that hospital ward, you really need to ask yourself, have you mastered these clinical clues? Do you know exactly where to place your stethoscope, exactly what to look for on the ECG, and exactly how to fire back at the examiner's tough questions? Remember, preparation is half the victory. Are you ready to become the 50% that succeeds?